Okay. Do you know what the definition of, hello, can you hear me?
Yes, sir. Yes, sir.
Okay. You know what an infertility means? Basically, infertility means people who cannot procreate. That means they can't have a children or offspring. That we define as an infertility. But we need to give a time frame for it. Hello, are you able to understand? Are you able to hear me?
Yes, sir.
Okay. So if a couple are not able to conceive in a year's time of unprotected intercourse, then we define as an infertility. However, if the woman is older than 35, even 6 months of duration is enough. Is it okay? Can you hear me?
Yes, sir.
Okay. Then there is also a issue called infecundity. That means unable to produce or procreate a live birth. That means they can't take the baby home. So that is called infecundity. It is usually two types, a primary and a secondary. Okay?
Okay.
Primary means they never have been pregnant. Secondary means they have been pregnant, but they don't have any further child.
Right.
Does that make sense? Okay? Hello?
Yes, sir. Okay.
Okay. What's the incidence of it? Meaning how many women or how many men or how many couples have? I mean, basically in the world population, approximately around 15% of the couples, that means we are talking about the age group from 15 or 20 years to 40 years of age group, 15% of them cannot have or have difficulty in getting pregnant or having a child. Does that make sense? Is that okay? Hello?
So 15% of in the world statistics.
Yes, around the world statistics. Roughly around 15% of the couple across the globe may have a difficulty in getting conceived or they don't have a child.
Okay, sir.
Okay. But important thing is, it's a woman's age, which is a critical. The older the woman, the more and more difficult for her to get conceived or get pregnant. Okay? Now, if you see that, they have classified based on the age group. Roughly, if they are 25 to 30, 5% to 6%, 30 to 35, 10%, 35 to 40, almost 20%. Does that make sense?
Yes, sir. With the age group, more the chances of people come under the group of infertility.
Yes. The more they enter the age group of a woman, the more difficult or more this one. It can be first time, second time. It can be primary or second time, but that's how it is. Okay. Now next question you could probably ask is, why does the woman's age is related to the fertility of the issue? Women are born with a definite number of eggs, which we call as the oocytes. There are around 2 million. So, if a girl child is born, she has born with around 2 million oocytes. Does that make sense?
Yes.
Now, it keeps on decreasing year on year till the girl hits puberty. By the time the girl hits puberty, she is left with 500,000. That's around 500,000 or 400,000, something like that. Okay. Now, by the time they go to menopause, which is around 50 or 51, they are almost less than 1,000.
As age decreases, number of oocytes decreases.
Now, basically, every month, one oocyte has to be released every month on the day of the puberty, right?
Right.
So, in order to release one egg or one oocyte, roughly around 500 of them will be sacrificed. In other words, 500 oocytes are being sacrificed, or from that pool of 500 oocytes, only one proper oocyte will come out. Okay?
Okay.
Henceforth, the oocyte quantity, the time they are born, is always important and it's a finite. And the quality also, whatever they inherit, that's the quality. It cannot be changed much. Okay. As age slowly goes to about 30, 35, even though the quality of the eggs and the number of eggs are good, chances of getting pregnant also declines. Even though the quality may be good and the number may be good. That we call as a secondary. Okay. And once nearing 40, it's a steep fall. And simultaneously, even if the women at the elderly age group they conceive, they tend to have more miscarriages or abnormal child. Is that clear?
Yes, sir.
Right. Now, how do we actually try to diagnose the infertility? Basically, it's a process of what we call as an exclusion. If you see, people come to the doctors to find if they are not conceived, right? Why they are not conceived. So we have to first exclude the things, not trying to diagnose, but actually trying to exclude the things. For example, are they actually, the wife and husband, are they actually having a proper regular sexual intercourse or not? Because that's important. We have to find a clear cause or a possible cause. Or if these causes are not able to find out, we classify them as unexplained. Is that okay?
True.
Causes of infertility in two main groups, actually. Male one and the female one. Okay. The male contributes to around 24%, roughly. So, for example, if you are sitting in a clinic and people are coming, not that doctor, I'm not having children, wife and husband, 1 in 4 couple who walks in actually will have a male problem.
Okay.
Remaining 4 or maybe 2 in 3 will have a female factor or combine both male and female. Okay. Now, can you see that a uterus picture on your screen?
Yes, sir.
And then can you see those 2 ovaries and fallopian tubes either side?
Yes.
On the left side of your hand, on the ovary, can you see that red mark on the ovary?
No, sir.
Okay. Can you see both ovaries? Then can you see a blue-green dot uterus?
So there's a blue and red dot on the left side, left ovary, near.
Absolutely. So that's where what happens is from the red dot, that's where the egg is released. The egg travels all the way here. The sperm will start from here. Egg and sperm meet in this tube here. And the new life starts and that gets attached and then get attached here. Did you follow my cursor, how it happens?
Yes, sir.
Okay. So anything when there is a problem in this whole journey can lead to cause of fertility, right?
And yes, sir.
So if they are not releasing egg from these ovaries, it is called ovulation problems or ovulation defects. Roughly again 25% of them to 30%. Okay. Now I've discussed you about the male sperm factor, which is another 25%. Okay.
Okay.
Now there is a factor called tubal factor. That means these tubes are absent, blocked, infected, etc., which again around 15%. Okay. Sometimes after doing all these steps, you will not find any particular reason. Then you call endometriosis. Unexplained. I'm sorry. It's called unexplained. Again, 15% of them can be unexplained. You don't find any causes. Okay? Can you hear me?
Yes, sir. Yes, sir.
And then something called endometriosis, another 5%. So all these constitute the basic problems why people don't conceive. Okay. So when you are coming to evaluate, sorry?
Uterine factor.
Yes. I'm coming to that point in the next slide. Now, if you see the slide now, if you have to evaluate a couple who are not getting pregnant, we have to evaluate the ovary. You know, with the ovary, we have to evaluate the tube. We have to evaluate the corpus. We have to evaluate the cervix. I'll go back to the slide. So this is the one we have to evaluate. We have to evaluate ovary, right?
Yes, sir.
We have to evaluate the tube, right?
Corpus.
The fallopian tubes.
Yes, sir.
We have to evaluate the whole uterus. In this uterus, you will split up into two forms. One is the corpus, that is upper half. Lower is the
Cervix.
lower half. So these two forms the uterine factors. Okay? Sometimes
Yes,
all these uterus, tubes, ovaries, everything is inside the abdomen, in the peritoneum. There could be some peritoneal causes, like there may be uterus and the fallopian tubes are sticky or closed or whatever it is, some adhesions and stuff. That leads to what you call as the peritoneal causes or other causes. Okay.
Yes.
Next comes the male factor. First and foremost important in man to be is the check for the semen analysis, that is sperm. Okay? Hello, can you hear me right?
Yes, sir.
Yes.
Sir, your voice is clear, sir. I can hear you.
Oh, thank God. I don't know what's hearing now. That's why I'm repeating myself. Okay. In the sperm, most important is the sperm analysis. Okay. Now, you have to give some instructions to the man before he's come for the sperm analysis. You have to tell him that he at least need to have 3 days of abstinence. Okay. And then he has to collect by an ejaculation. Most of the time, it is better to get his semen analysis done in a fertility unit or ejaculate in a fertility unit where they can assess the semen well. Now, when you assess the semen, I have not put that on the slide. That's why I'm trying to tell you, because it's important to understand this. The semen is actually assessed on a reference values of World Health Organization guidelines. We follow 2010 WHO guidelines or manual, where minimal count we should be at least 15 million. So it's very important that on what basis they are comparing it. WHO has got so many manuals. Every 5 to 10 years they'll get a manual. So if we are following 2010, we need to, that's the latest, we need to keep it in at least 15 million count. Okay? Then comes, after the count, most important is the motility. That means how many of the sperms are going forward. At least we need 40% of them being mobile. Okay? And again in the motility is again divided into how are they moving. Are they fast movers, slow movers, or so fast movers are called progressive motility, that means which go forward. Slow movers are slow like a walker, so you are just going. Non-movers are absent movers. So we need at least 40% of the total sperm to move, out of which another 30% should go forward, that is progressive motility. Okay? And then the shape of the sperm, what is the head, the sperm morphology, we call this as a motility and a morphology. Morphology is the shape, which means the head and a neck and a tail. At least 4% of the normal sperm. So if somebody has a 15 million count, it's expected 7.5 million is going forward, out of which at least 3.5 should be progressive motility, at least 5% should be normal shapes. So this is very, very important. And then it has to be, and the other parameters which you look is the volume, how much the semen they have produced, how long it takes to liquefy, what is the pH, is there a fructose present, any infection like white blood cells, etc. is there. All these things will be evaluated. That's why they call ejaculate characteristics or immunology. Is it okay? Do you able to understand what I'm trying to tell? Because that slide is not here.
Yes, sir. Yes, sir.
And for reference one, you could always check WHO 2010 semen guidelines.
Yes, sir.
There are many semen criteria because the semen has to be compared with some reference criteria. So you got 150 in the market like Cougars. Nowadays it's a computer resisted, all that. But generally everybody follows, or most of them follows World Health Organization WHO criteria. Okay. So when you start to investigate, or when you try to find the history from a couple, these are the things you need to ask. First and foremost thing you need to ask women is the age. Probably the age above 35 might be a lower chances of pregnancy. If somebody has an issue with an ectopic pregnancy, somebody with a tubal problem, previous infections, previous surgeries, previous some chemoradiotherapy, periods problem, that means amenorrhea, oligomenorrhea, that means no periods, scanty periods, heavy periods, all these things need to be actually evaluated or discussed. You have to take the history of those things. Similarly, when it comes to the man, you have to see whether there is an abnormal semen analysis pattern or not. Any history of sexually transmitted infections, cryptorchidism, because some men, at least less than 1% of the men, do not have testes descended. It's probably in the abdomen, which we call as the cryptorchidism. Okay? Whether she had any chemotherapy or radiotherapy, all these things you need to find out. Any previous surgery with respect to the urogenital system. Also, it's important whether they have a vasectomy or not. Sometimes people get married second time or different partners. So all these things you need to ask in the history. Okay. So coming back to the ovarian cause of the female. Commonest we call is the polycystic ovarian syndrome. You heard of this called PCO?
Yes, sir, PCO.
Yes. Now, it is basically 60 or 70% women with polycystic ovaries will be on a higher side of the weight. That means BMI more than 25 up to 30. They have a problem in releasing the egg, which you call ovulatory dysfunction or anovulation, which constitutes almost 20 to 30% of the infertile couple. They may also have some prolactin issues. So all this lead to what we call as non-releasing of the oocytes or anovulation. Can you see this ovary? Did you people have a chance to look at a laparoscopy or something like that before?
Yes, sir.
Okay. Did you see that how big, glistening, wide, big ovaries look like?
Yes, sir.
So this is how they usually look at it. On a scan, they look like a pearl string. You small follicles surrounded in the ovary, in the peripheral region, like a necklace pattern.
Yes, sir.
You have seen these type of scans before?
No, sir.
Yeah, if your PCO scanning is there, see this is where the small follicles. Can you see this?
Yes, sir. Yes, sir.
Yeah, in the periphery. So these women will be on a higher side weight, periods will be irregular, scan shows polycystic. Poly means many, cystic means fluid-filled cavities. Ovaries are in the ovaries, that's why you call polycystic ovaries. Okay. And they also can have hormonal disturbances where they tend to have a male pattern of features like facial hair, sometimes can also, if you do a blood test, male hormones are higher like testosterone, androstenedione, all this can be higher side. Okay. Next comes the tubal problem. The tubal problem we call pelvic inflammatory disease. Pelvis means pelvis. Inflammatory means any infection. So tubes can be blocked. Can you see this picture here? Where the left tube is blocked, swollen, all this?
Yes, sir. Above the ovary.
Have you seen the laparoscopy when they do a dye test?
Yes, sir.
So if the dye test is not coming, it is sticky, black, brown, then it's all tubal disease. Okay. So all, if you see the TTT mark is all tubes, and if you see there's relations where it is got stuck, where we push a dye, it may not come. So, like I said, when you're taking history, you need to ask about their age, how long they have been trying. If they're trying more than 1 year and they are less than 30 years, it's okay. If they're trying more than 6 months and the woman is 35 years of age, it is actually better to go for some evaluation. You have to ask whether it's a type of fertility. Primary, that is the first time or the second time. Cycles, whether they are regular or irregular, whether they had any tubal issues. All this stuff you need to ask. When you're trying to examine, you have to see the weight. Any facial hair, any breast milk or secretions, which suggests your hyperprolactinemia. We also have to see what are secondary sexual characters like breast development, pubic hair development, axilla or arm hair, because they may not hit the puberty properly because they may have some chromosomal issues or hormonal issues. Did you see anybody with a Turner's syndrome or something?
No, sir.
Yeah. They will not have, even if the girl may be years old, but they don't have any breast development or they don't have any pubic hair or axilla hair, then you need to see what is happening. That's all have to find out. Okay? And if there is a chance of pelvic examination, whether uterus is fixed or painful, all this stuff you need to know. Similarly, when it comes to man, you probably have to ask general health, smoking, alcohol, any previous infections. In men, it's very important to ask if they have a erectile dysfunction, because they need to ask, are they having a normal sexual intercourse? It's an average 2 to 3 times in a week. It's considered as normal. Okay? Whether we need to ask whether there is an erectile issues or ejaculatory issues, because unless we have that, we will not be able to find. Because at the end of the day, they may not be having a penetrative intercourse, and that's not relating to the pregnancy. Right?
Correct.
Okay. Now, some examination, not necessarily, basically you don't need to really examine man unless there is a specific reason you have said. If you are examining, you will examine about 5-6 things. Commonest, you need to check, make sure that there's no thyroid, his breasts are normal size, not very big, very small, no hernia problems. Then you need to say about the testicular size, scrotum, position of the testis, and the prostate. That's all you need to do, if at all you need it. But the history does not suggest any issues, you don't need. Okay. Now, after the examination, we need to proceed to what we call as a blood investigations. Like anything in the medicine, the investigations are basically split into blood tests and the imaging, and then any invasive testing. Blood tests are the most important blood tests in women in infertility, need to be done in second or third day of the period, maybe second or third day. They are follicular stimulating hormone FSH, luteal luteinizing hormone LH. We also have to do what we call as the estradiol, that is E2. And many people do the ultrasound scan also to check what is the follicle quantity and stuff. These blood tests are done to see the ovarian reserve. That means what is the capacity of the ovaries to make an egg. On the 21st or 22nd day of the period, we check the progesterone, whether it says us whether she's been ovulating or not. Okay. Now, based on which part of the world you are living, it's always important to see that the women are rubella positive. If they are not rubella positive, we may have to give a shot of a rubella injection to immunize against the rubella. Okay. And subsequently, we also have to make sure fallopian tubes are not blocked, because that's very important. If the fallopian tubes are blocked, then there's no point trying to do anything. So tubes testing is done by 3 ways. One, by intrasalpingogram, that means an X-ray with a dye pushing in, take a picture. Laparoscopy and dye test. You have seen laparoscopy, right?
Yes, sir.
You have seen HSG pictures also, fillings?
Yes, sir.
And we can do the same like HSG by pushing an ultrasound scan, by pushing a contrast dye, that's called HICOC, histocontrast sonography. So this is the HSG picture. Can you see the uterus, tubes and all that stuff?
Yes, sir. The right side is not.
Yeah, the picture is got it, but you can see this whole uterus is nice. The tube is lying delineated. This is where the dye is coming out in the pelvis. This is also dye is coming out. If there is not dye coming out, this becomes a big swallow like this, like this will become. Okay? This deviation, this all will not happen. Now, if you see this is actually a testing the tubes with the ultrasound by pushing a dye and doing a color Doppler. Can you see this? This is the uterus pushing the blood flow with a color Doppler coming out. Okay.
Hello?
Hello, can you hear me?
Sir, your voice is...
Can you see this dye which is coming out by color Doppler?
Yes, sir, from there.
Yes. So this is the other way of checking it.
Okay, sir.
And this is a laparoscopy where you see uterus, tubes, fallopian tubes, rectum, bowel, all that. Can you see that blue near the F, that black stuff? That's the blue dye which comes through. Okay. The problem sometimes is we need to do further tests based on we need anything. For example, if we find some issues in the uterus, we do a hysteroscopy. If we find some blood hormones, this one we do a prolactin, thyroid, testosterone to make sure things are all fine. By an ultrasound, we would be able to see uterine problems and the ovary. By hysteroscopy, we would be able to find, you know what hysteroscopy means?
Yes, sir. It's like a laparoscopy through the cervix and from the internal part of the uterus.
Perfect, perfect, yes. Have a good look inside. And if there is a polyp or stuff, we can take that out, or any fibroid can detect. Like that, we will do further. One additional. This is an ultrasound. Can you see endometrial cavity, myometrial wall, all that stuff? Quite nicely can be seen.
Yes, sir.
This is an endometrium, this is a myometrium, this is a whole cavity. And if you could see this black one here, round mass, this is a fibroid.
Yes, sir. Sir, fibroid in the myometrium, right?
Yes, growth in the myometrium. Now, I've discussed this. This is what we need to see for the semen. Volume around 2 ml, concentration around 20 million, initial fog only 50%, normal is 30. They say but 5 is okay as per the World Health Organization. If 1 is abnormal, you could ask them to repeat the sample in 3 days time. Okay. Now, based on that semen analysis, we may have to go further testing, like hormone testing. If there is no sperm or very low sperm, we need to check follicular stimulating hormone, luteinizing hormone, testosterone. Sometimes we have to do an ultrasound to see if there is a varicocele or something like that. Further, we may also have to test if the sperms in a semen analysis, all the sperms are clogged, like clumps and clumps. We may also look if there is any what we call as antibodies to that and all that stuff. Okay. So treatment. Basically, we have investigated, we have taken the history, we have come to the treatment, we need to find out the cause. We have found anovulation, that means egg is not releasing. Then we need to see, to give tablets or injections to see whether they make egg. Commonest tablet we use for anovulation is the clomiphene. You heard of this tablet called clomiphene? Hello?
Yes, sir.
You heard clomiphene, you heard, no? So you give some tablets which actually will lead to ovulation. That means make egg and release. If they are not responding to the drug, we can give injections. Let's say, and in polycystic, it's always important for them to lose some weight because sometimes the weight reduction itself will help them to ovulate. And if there is any breast secretion or hyperprolactinemia, just taking the medications of prolactin also will help. Now, if there is an issue with the tubes, we will not be able to do much. We may have to do some tubal surgery to make it open. Otherwise, we may actually try to resort to test tube baby, which we call as an IVF. You heard of this called IVF?
No, sir.
You didn't hear of in vitro fertilization, test tube baby?
Yes, sir. Yes, sir. Sorry.
That is what is IVF. So most of the time, if the female partner's tubes are a problem, it's an IVF. Okay. Now, if there is a male factor, we will not be able to do much. We might do what you call as an intrauterine insemination, which means we process the semen and inject the semen into the uterus. Okay?
Yes, sir.
Or we go for a test tube baby, which we call in vitro fertilization or ICSI. That means we take 1 month sperm, we inject in 1 month oocyte. If there is no sperm, obviously we do have to seek the help of a donor sperm, and then it's called a donor sperm. Okay. So on the scan, this is how the follicles will look. This is what you call a Oocyte. That means, can you see that one round oval shaped one? That's a oocyte. It's a magnified 500 times magnified. Can you see one small needle coming from the left side?
Yes, sir.
Inside that, there is a small sperm which they are injecting. That is called intracytoplasmic sperm injection. We tend to do when there is not enough count. And once we do that, this is how the embryo looks. As the embryo grows, if I go back, this is the embryo on a third day after the injection of the sperm. This is the fifth day. So this is called a blastocyst, where we could be implanting or putting back in the uterus. And then the baby is like this. Clear?
Yes, sir.
You heard of what you call it, the endometriosis?
Yes, sir. There's
Basically,
endometriosis issue in other places of apart from the endometrium.
Fantastic, fantastic. Basically, any endometrial tissue outside the uterus or endometrium is called endometriosis. If it goes in the uterus, myometrium of the uterus, it's called adenomyosis. Okay. Now it's around again 10% of the women you tend to find. Most of the time, they will have a difficulty in getting pregnant. We really don't know why it happens, but most of the time we think that retrograde menstruation, that means bleeding is going back, periods are going back, and then there is some metaplasia, so that way it happens. Three important things they complain: very bad pain during the periods, in and around the time, few days before, during and after, heavy periods usually. They also have complaints that a lot of dyspareunia. You understand what a dyspareunia means? Hello? Hello, can you hear me?
The dyspareunia, difficulty in intercourse.
Pain during the intercourse.
Sorry, yes.
So, and they may also have a bowel disease, and they also have difficulty in pregnanting. All these three features present, we go as a endometriosis. Now, the problem with endometriosis is diagnosis. Not all of them will be easily diagnosed. Most of the time, you might need a laparoscopy. Okay. When you do an internal examination, you tend to find retroverted or fixed uterus, and which is painful. Usually diagnosis is by laparoscopy, where you tend to find a spots. I will try to show you later. Did you see endometriotic spots in laparoscopy before?
Yes, sir. Like
Very
white color.
Yes, white, black, gunpowder, this one. If those are in the ovary, it is called chocolate cyst. See that black dots, powder, can you see?
Yes, sir. Yes, sir.
This red colored. All the scarring. Okay. Now problem with is treatment is difficult. You cannot cure it because it's normal. And till you stop the period, they will have this issue. So depends upon what it is. You have to. If there is a pain, it's a different treatment. If it's a fertility, it's a different treatment. Usually, if it is a pain, you can give a pain relief medication or make the periods less by giving combined contraceptive pill or tablets or injections to stop the periods. You understand that?
Okay.
Obviously, which one to pick up depends upon their symptoms and side effects. People who are okay with pain relief, they are okay. If people want less periods, then combine contraceptive pills. If people do not want periods at all, then you can give injections to stop the periods. If you come to
Yes, then how much can we prolong that if we completely avoid having periods if that is what they choose? So
But
wouldn't that
even
affect the
it is a question. If they are on to time to have children, then obviously it's not a good sign. If they are finished with the a family, then you could continue for 5 to 6 years at least, right? Minimum, based on till they get this one.
Okay.
You go for surgery, you do a laparoscopy, and you try to diathermize all the spots and burn by cautery or laser. But the best treatment is to take the uterus, tubes, ovaries out. Once you take uterus, tubes, ovaries out, then there is no. But she cannot get pregnant. So it depends upon what does she wants. Fertility, this is the biggest challenge. In fertility, this medical management is useless because they stop the periods and they don't. Contraceptive will stop the period, right?
Yes, sir.
They don't ovulate, so there is no point. So if there is a fertility, probably you may have to do a laparoscopy and burn some cyst or cyst is there, take the cyst or burn them and go for assisted reproductive technique. That means either IUI or IVF or test tube. Okay.
Yes, sir. So what is the definite treatment for a chocolate system?
Take the cyst out. That's the definite treatment. It will recur, but probably that's what we need to do. If it's coming more and more, you need to take that ovary out.
So that time also only ovaries, or it's better to do a hysterectomy at the same time?
Usually, if you take ovary, that's fine. But the thing is, if they finish the family, the best treatment would be taking both the ovaries out and the hysterectomy. But that's not ideal because ovaries do protect the bones, right?
Yes, sir.
So that's my challenge.
Yes, sir.
Any questions?
So what is the medical management given in infertility apart from clomiphene citrate, sir, and how is the dosage and all?
See, clomiphene citrate you start. There are I told you 3 types. One is the ovulation induction drugs, which is clomiphene. You start with 50 milligrams from 2nd day to the 6th day or 2nd day to the 3rd day to 7th day. You do a follicular scan to see if the follicles are growing.
Okay.
Either you tell them time intercourse or either you tell them to have an IUI. If clomiphene is not responding, women not responding to 50 milligrams of clomiphene, you could increase to 100 or up to 150, but not more than 150. People do use, but generally you could try this clomiphene if she is ovulating for 6 months. Okay? If they are not responding to clomiphene, you could add gonadotropin injections. Okay?
And day 3 or 4?
Yeah, HMG. Like you can start with 37.5 or 75 or 150. But before that, you can also try alternative medications to clomiphene, like letrozole. You heard of this tablet called letrozole?
Yes, sir.
Again, 2.5 milligrams twice daily from day 3 to day 7 or day 2 to day 6.
Okay.
You can also use anastrozole. You can also use tamoxifen. They are all ovulating induction drugs. Okay?
Yes, sir.
But all of them need ultrasound scan to follow up.
Yes, sir, got it.
So, are you the medical? I mean, I'm sorry, I'm not clearly aware what level. Are you the medical students, or you have finished your obstetrics, or then you are in the post-graduation of what exactly, where exactly you are placed and doing?
So we are postgraduate. We are doing OBG, MD in OBG right now, sir. So in the group of students are different. Even first year, second year, third year, all are together. Sir. Supposed to be together in this meeting actually.
Okay. Oh, so all of them for the OBG you are doing. This is not all. I was still thinking the medical students. That's the biggest challenge we have here. When we don't see, okay. Fair enough. Oh. So do you operate a lot and do you see a lot of infertile patients?
Yes, sir. There's a weekly infertility OT clinic of laparoscopy. OT that does done the laparoscopics and everything.
Yeah, which place is it?
Sir, Muslim Maternity Hospital, Chadarpet, Hyderabad.
Oh, okay. Okay. Surprisingly, then you probably need one. I'll do one thing. I'll try to switch some presentation so that most of post-graduation things will come. Okay, I'll get that presentation on. Hello?
Yes, sir. This was very basic actually. I wanted it to be a little more in detail.
Yes, do one thing. Actually, this is where the problem comes, because when we do not know who we are dealing with, fair enough. Okay. Can you see this presentation? The new one?
Yes, sir.
So let's go. So look, what are the goals of the ovulation induction? Let's go. Sorry, it was very basic. I was trying to tell you because I was thinking of medical students, to be honest with you. Okay. Hello?
Yes, sir.
Hello?
Yes, sir. I can hear you.
Okay. Can you see this new presentation called Goals of Ovulation Induction?
Yes, sir.
Can you see or you cannot?
Yes, sir. I can see.
Okay. See, if, I'm sorry, I know we went very basic. Now we'll go to the most of the, we'll straight away go to the postgraduate level of teaching now. See, there are some goals of ovulation induction in infertility. One, you need to induce single follicle, which we call as a monofollicular. Okay, that should lead to a single pregnancy and a healthy birth of life. That is what is the one. Second goal is you have to start with simplest in the smallest dose to begin with.
Okay.
Okay, and the idea should be single pregnancy and minimal multiples, and they should not be or zero or less than PCO or with OHSS. Is that clear? Can you see this slide there?
Yes, sir.
Now you know about this slide, right? It's important that we do know about this slide. Otherwise, we will like. So it's you have to understand HPO axis, how they work. The hypothalamus releasing hormones, gonadotropin releasing hormones. They act on pituitary. Pituitary releases FSH-LH. That will make estrogens from the ovary. The estrogens will go and suppress back in hypothalamus. But estrogen also have a positive effect on the a little bit on the hypothalamus to get the pituitary. You are aware of the ovulation HPO axis, right? This one?
Yes, sir.
Okay. I'll skip this. Now, this is the most important slide for a postgraduate level. If you see on the left side, see for a recruitment, when do you think the recruitment happens? Okay. Do you know when the follicles will recruit it? Anisha, I think we need to do something slightly different. I'm sorry, I was under the impression that the medical students I'm teaching. Otherwise, I would have had all the ovulation induction in a different way. Arsha, do one thing.
Yes, sir.
You mail me what are your requirements. I will again reconnect with as per your requirements through Satish, so that we'll have a more postgraduate level of teaching rather than the basic medical student teaching.
Yes, sir. Even next time, please ask the Texila University to make it clear before the class if it is a postgraduate teaching or undergraduate
You have to
teaching.
make it clear, Satish, not me.
Yes, sir.
See, because I was told to just do the basic fertility. That's the issue will come. Okay. So I am more than happy to do this stuff, but I have to be clear how many people are coming, who are coming. Based on that, I'll do. Okay.
Yes, sir. Sir, actually, all of us are postgraduate students only, sir. No one is undergraduate.
Yeah, I was under the impression that it's the medical students. So that's why I have to cut down. But it's not difficult. It's not a question of the only thing is we wasted time. That's my intention. Otherwise, I would have started with a different.